Everybody, how you all doing? I'm Dr. Menorrhagia, a pathologist. So I'm here to give you some important tips for your examinations, especially USMLE and BME. So let's do some hematology concepts today. Hello everyone, so let's discuss iron deficiency anemia today. So as you all know, deficiency of iron is the most common nutritional deficiency in the world, and important causes for iron deficiency anemia include increased iron demand. For example, in pregnancy, there is an increased physiological need for iron in the body. Another reason could be a decreased supply due to a dietary deficiency, and this dietary deficiency is a common etiology seen in the developed world. Next reasons related to diet that lead to iron deficiency anemia include an infant's diet that is entirely based on cow's milk, or the elderly diet, which is the so-called tea and toast diet, leads to deficiency of iron. Gastrointestinal tract related causes include post-gastrectomy or malabsorptive diseases like inflammatory bowel disease of the duodenum, celiac disease, autoimmune atrophic gastritis, or H.pylori infection. Another group of conditions that lead to iron deficiency anemia are related to increased losses of iron from the body. Now this could be due to a hemorrhage. Obvious examples are menorrhagia, abnormal uterine bleeding, or frank gastrointestinal bleeding. Some patients would present with an occult blood loss. That could be a case with a person who has peptic ulcer disease or a gastrointestinal cancer. Few chronic intravascular hemolytic diseases like PNH, cardiac valve RBC fragmentation could also lead to chronic iron loss. Clinical features of iron deficiency anemia usually include fatigue, and this fatigue usually develops before the clinical anemia appears. The other usual signs and symptoms of anemia include headache, lightheadedness, malaise, weakness, and decreased exercise tolerance, along with dyspnea, palpitations, or dizziness in some patients. Iron deficient patients may also have brittle hair and nail changes. Now, in these patients, the nails sometimes become brittle and spoon-shaped, and this is known as koilonychia. Another feature is Pica. Now, Pica is an appetite for non-food substances, for example, ice, paint, dirt, and this is a very important feature with iron deficiency anemia. Some patients who present with restless leg syndrome may also have iron deficiency anemia. Now, investigations for iron deficiency anemia include looking at the iron indices along with soluble transferrin receptor levels. Low ferritin levels are usually diagnostic of iron deficiency anemia, where ferritin level below 18 microgram per liter is directly diagnostic of iron deficiency. Other investigations include looking at indices. So first important is serum iron level. Now, in case of iron deficiency, the serum iron level is going to be very low. Secondly, we look at total iron binding capacity. Now, this total iron binding capacity, or TIBC, is a measure of transferrin, and as you all know, transferrin is a transporter of iron in the blood. In case a patient has iron deficiency, this transporter is very high in the blood, thus TIBC level goes very high, or we can say the total iron binding capacity in that patient will be very high as the body wants more and more iron transported to the bone marrow. Transferrin saturation will be low as the saturation of transferrin with iron in this case is going to be low. One thing to note here is that ferritin is an acute phase reactant, and it is elevated in the setting of inflammatory conditions and liver disease as all other acute phase reactants. Thereby, this falsely indicates that iron stores are adequate. So serum ferritin, as you have realized, is unreliable in these settings, and this necessitates further workup by measuring soluble transferrin receptor levels. Now, in case of iron deficiency anemia, the level of soluble transferrin receptor levels will be high, and this can help you to rule out any other conflicting result due to co-presence of any other disease. Free erythrocyte protoporphyrin levels are going to be high in iron deficiency as there is less iron for combination for making heme molecules. Red cell distribution width again is high in iron deficiency anemia, and this is an indicator of high degree of anisocytosis, that is the variation in red cell size. So this can help you distinguish iron deficiency anemia from thalassemias where the RDW is usually close to normal. Important features seen on peripheral blood film in case of iron deficiency are hypochromic and microcytic RBCs with low hemoglobin levels due to the lack of iron. Hypochromic is because of increased central pallor, and microcytic is MCV generally less than 80 femtoliters. Pencil forms and anisocytosis along with target cells are occasionally also noted. Bone marrow examination is the gold standard for diagnosis, but this is rarely done for iron deficiency as it is an invasive technique. But in case it is done, it will show a decreased iron level in macrophages and in erythroid precursors known as sideroblasts on staining with an iron stain, that is a Prussian blue stain. The intermediate and late erythroblasts usually show micronormoblastic maturation in the marrow. An important concept related to iron deficiency anemia is that iron deficiency anemia is a common presentation of chronic lower gastrointestinal bleeds. Now, this could be one case where a patient has right-sided colorectal cancer or angiodysplasia. In males and in postmenopausal women presenting with iron deficiency, a gastrointestinal workup like gastroscopy, colonoscopy is always done. Another related concept is a syndrome called Plummer-Vinson syndrome. Now, this comprises of features of iron deficiency along with esophageal dysphagia, glossitis, and stomatitis. Finally, the treatment for iron deficiency includes treatment for underlying causes and giving supplementation in the form of capsules or syrups. This contains ferrous sulfate, ferrous gluconate, or ferrous fumarate usually. This supplementation is given until the anemia corrects and is continued up to 3 months until the serum ferritin returns back to normal. Oral iron should preferably be taken with citrus juice as vitamin C enhances its absorption. IV iron sucrose or dextrans can be used if your patients cannot tolerate or absorb oral iron. Reticulocyte count will usually begin to increase after 1 week of iron therapy, and this indicates a positive response to therapy. Now finally, let's look at a review question on this topic. You can post your answers in the comments below. Thank you. Hey everybody, thanks for watching the video. Do comment and subscribe if you like the video. Press the like button. Thank you. See you in the next video.